Welcome to our Beyond 20 campaign, a celebration of One Joshua Group's 20 years of service excellence. This is a One Joshua Group production, providing access to information and experts to help improve quality of life and health outcomes.
Thank you for joining us for our Beyond 20 series and beyond as we celebrate One Joshua Group's 20th anniversary and look forward to meeting the challenges of public health, improved health outcome, and the communities and the people that we serve. We so much enjoy talking about this on a regular basis and are joined by a friend of One Joshua Group, Dr. Modele Ogunniyi. And Dr. Ogunniyi is currently the professor of medicine in the Division of Cardiology at Emory University School of Medicine. Thank you for joining us, Dr. Ogunniyi.
Thank you for having me, Mr. Payne. It's always a
Now,
delight to be back with family.
and we so greatly appreciate your being here. Now, Dr. Ogunniyi, right now you are professor of medicine at Emory University in the Division of Cardiology. So you haven't always been professor of medicine in the Division of Cardiology. How did you arrive at this prestigious position? We'd like to know something about that journey.
Thank you for that question. I think I always reflect back as someone coming from what I like to describe as humble roots. So I was born in the Bronx while my father was a medical resident at the Albert Einstein College of Medicine when he spent his internship there and subsequently transferred to Howard University to complete his internal medicine residency. But at the young age of 3, we relocated back to Nigeria where I went to medical school. And working in Nigeria as a medical student and during our rotations, I had the opportunity to have my first public health exposure in a village where we worked with the indigents under the supervision of a local doctor to control chronic diseases such as hypertension and an exposure to eradicating guinea worm. In fact, that village in Nigeria was one of the projects that President Jimmy Carter engaged in to eradicate guinea worms. And that started my love for public health. And after completing my internship in Nigeria, I decided to come back to the United States to expose myself and learn about public health at the Johns Hopkins School of Public Health. And after completing that, I was privileged to get a joint fellowship through the Association of Teachers of Preventive Medicine that afforded me the opportunity to work with foremost researchers both at the Centers for Disease Control and the International Society of Hypertension in Blacks, where I was fortunate to work with you and the staff who were really interested in eliminating disparities in hypertension. So, working with you for 2 years on our community programs, cardiovascular education, and really being at the forefront of studying disparities, mostly in hypertension among Blacks, has formed the foundation for me in my career. After this, I was fortunate to do a residency in internal medicine at Morehouse School of Medicine, introduced to that program by the late great Dr. Reed, who really has served as a mentor for me in my early career when I was trying to decide how to work this journey. After my internal medicine residency at Morehouse and continued partnership with the CDC, where I will do elective rotations during my residency, I completed my cardiology fellowship at Vanderbilt. And through my training, I was able to always follow my passion of improving cardiovascular disease outcomes for Black. So at Vanderbilt, as part of the Mehari ABC Vanderbilt Alliance, I was able to work at the Nashville General. My continuity clinic was at Nashville General, where we were able to care for the patients. And since then, since completion of my fellowship, I have been at Emory University. My clinical practice is based at Grady, where I did my initial training. And now I serve as one of the medical directors for the Grady Heart Failure Program, where we have focused on addressing social determinants of health in addition to medical care to improve outcomes for our patients with heart failure. So I think I call myself a public health cardiologist, because I look at my patients in the context of their environment. Because as you know, the outcomes for patients, especially patients with cardiovascular disease, is driven primarily by social determinants of health, which contributes to 80% of their outcomes. The
Mm-hmm.
medical care that we provide only is responsible for about 10 to 20% of outcomes. So I think that working at Grady Memorial Hospital has really helped me to fulfill that passion of eliminating disparities in cardiovascular disease, and has helped me to translate this effort from a local perspective to national platforms, such as the Association of Black Cardiologists, where I serve as the board, and the American College of Cardiology, where I am a member of the Health Equity Task Force, the D&I committee, and the Cardiovascular Disease Committee. So I will say that I've been fortunate to have mentors and sponsors and allies who believed in me and who have supported me along this journey to fulfill my passion of ensuring equitable cardiovascular care for all. And I know that's a mouthful. Thank you.
So, Dr. Ogunniyi, it's a mouthful because it's a lot of work in your championship. And the circle that you've come, you talked about some of your mentors, and now to be a mentor for so many people and leading the pathway, not just leading, but demonstrating the passion that you talked about and being a public health servant cardiologist. The relationship of servant leadership is so critically important to that 10% that you talked about in improving health outcomes. Why cardiology? What made you land there?
Why cardiology? That is a very good question. So while I was at Hopkins, my dissertation was to study hypertension in the Black population under the mentorship of Dr. Martha Hill, who was actually the dean of the School of Nursing.
Nursing.
And as I went through, we had to conduct interviews in East Baltimore. And as I went from house to house with our team, interviewing young Black men, two things stood out to me. Just the burden of hypertension in young Black men, mostly between their 30s and 40s, and the degree of poverty, ignorance, and other adverse social determinants of health that I saw in the East Baltimore neighborhood, just right very near to the prestigious Johns
Mm-hmm.
Hopkins. And I was able to draw the corollary between these social determinants of health from the community that I was coming from in Nigeria. So that's what first sparked my interest in hypertension, and that is the leading cause of death in Black people, and really the leading risk factor for the increased cardiovascular death in minority populations. And as I went on, I built in my research and my clinical career, I built on that premise to figure out why we have such a disproportionate mortality, especially among Black populations. And that has been kind of some of what the work, the clinical trials, the research, the papers I've published. And
Mm-hmm.
I was fortunate under the mentorship of Dr. Giles and Dr. Menser to be able to publish that first paper as a research fellow at the CDC on hypertension in Blacks. And 20 years later, we were able to update that to look at race, ethnicity, and Hypertension, published in the in the Journal of American College of Cardiology, in collaboration with Dr. Keith Ferdinand and Dr. Commodore Menser, Yvonne Commodore Menser, who is a nurse researcher at Hopkins.
At
So I
Hopkins.
think that that has laid the foundation, looking at hypertension and looking at how we can ensure equitable control of hypertension, both on the local scene as well as on the national scene.
So you certainly mentioned other champions like Dr. Giles and Dr. George Mensa, Dr. Commodore Mensa, and Dr. Reed. So certainly you stand now shoulder to shoulder with those giants that were your mentor. Congratulations on that. So we will look forward to see those 12-year-olds who look at their mothers and their families and their friends to see what it really takes to be a champion, to help people improve their lives, and most of all their quality of life, and understanding that the poverty and those issues really are not a determinant of health long term, but much more so a driver of health. Now, you talked about something that we hear about, don't hear about it as much as a silent killer as we did before. This whole high blood pressure risk factor. What contributes so frequently? And I know you do work in women as well. What are the contributing factors so frequently of high blood pressure in people of color and women?
So that is a very good question. And when we think about people of color and women, we categorize these people as underrepresented groups because that gives us a chance to focus on factors. When we talk about people of color and hypertension, we're looking at modifiable and non-modifiable risk factors. But there are emerging factors now that we know play a significant role, and that, like you called, I like what you called it, social drivers or social determinants of health or structural determinants of health. We know that in addition to the preponderance of cardiovascular risk factors, such as things that we can change, genetics, family history, and modifiable risk factors such as the presence of diabetes, obesity, smoking, and unhealthy life habits. We now know that there is a significant role that the environment plays, and by that, I'll like to talk about the impact of racism, bias, and discrimination on these health outcomes. Various researchers have shown that there is a positive relationship between the impact of both racism, be it interpersonal, structural, institutional racism, and bias and discrimination on high blood pressure and its outcomes. And also, we know that when we talk about social determinants of health, which I will describe as where people play, where people work, where they pray, where they worship, the environment where people are, the drivers in that environment also have a part to play if we're to achieve equitable hypertension control. With regards to women, you are also familiar with the impact, with the current focus on Black maternal morbidity and mortality. And for women of color, especially Black women, 4 times mortality compared to the general population, really driven by cardiovascular outcomes. So that's one area also that I've expanded my work into. And what we're finding, if you ask me what is the physiological basis for preeclampsia, where researchers are currently looking into that. But one thing we do know, that the impact of the structural determinants of health play a significant role in why we have increased mortality from hypertensive disorders of pregnancy, and has a community of researchers, policymakers, clinicians, and we need to embark on a patient-centered collaborative framework that really places at the focus the patient and the environment in which they find themselves, the access to healthy fruits and vegetables, the political drivers of health, the contribution of policies such as redlining, the policies that surround reproductive health, access to affordable medications, access to transportation, and things that really drive the social determinants of health that impact how our patients
Mhm.
access care. I think
Mhm.
that also, as we talk about the high burden of hypertension, there's a need for us to think outside the box, to think about a collaborative team based approach. Gone are the days where the physicians think they know it all. I think that in order to achieve equitable hypertension control, it has to be a team effort involving
Mhm.
nurses, nurse
Mhm.
practitioners, community health workers who are really skilled in looking at the other factors that drive blood pressure
Mhm.
control. And we can talk about other policies such as ensuring equitable access to digital technologies, self measured blood pressure, and other things that can advance
Mhm.
high blood pressure control.
So that goes directly to our next question. And those champions like Dr. Martha Hill, who was actually the first nurse president of the American Heart Association and dean of the College of Nursing at Johns Hopkins, and of course, Dr. Ferdinand and others that you mentioned. And you did share with us that there are, although challenges, that there are still opportunities where we can bridge the gap between science and public policies. Can you share with us in your work, Dr. Ogunniyi, some of the opportunities and the challenges where we can include in a multidisciplinary and interdisciplinary approaches to improve policies and also improve health outcomes?
I think that that is a very important but complex question. I think that looking at the science aspect and research aspect, one important thing is that we have to be at the table. And being at the table, I would like to
Mhm.
talk about like diversity and diversity of the leadership of people who are promoting the science and doing the science work. Part of my interest is in diversity in clinical trials. And when you talk about research, when people are making decisions to engage in clinical trials, who are the members of the steering committee? Who are the members of the
Mhm.
leadership? Often you find out like minoritized people of color who are investigators are the ones in the hospitals, in the clinical centers, in the community centers with the patients, and you have sponsors and leaders that are not representative coming to these clinicians, these community health organizations, because now the FDA has a mandate about diversity in clinical trials. But I think that as a community, as a science community, as a research community, we need to step back and make sure at the design of clinical
Mhm.
trials, the design of research, we bring in a diverse group
Mhm.
of experts. I know you're
Mhm.
familiar with the work that shows diversity drives excellence, be it research, be it clinical care, be it training. Having a diverse team and having diverse
Mhm.
voices actually drives excellence, and it leads to improved patient outcomes. So
Mhm.
I think that it's a work in progress because the policies mandating it, but it starts from the pre-planning phase, having
Mhm.
one, a patient voice, having the input of patients, the important stakeholders, and making sure that the leadership reflects the community that we want to improve their outcomes. So having diverse representations in the leadership, in the implementation of the trial, and even in the study group. So talking about multidisciplinary team, our team has had success in enrolling the highest number of diverse patients of color in clinical trials. And the way we have done this over the past 10 years is because the people who execute the trials, the investigators, the study coordinators, are people who look like the patients we're
Mhm.
trying to enroll. So I know that the element of trust, and you have taught me a lot of history, and my mind goes back to the Tuskegee trials. And that is
Mm,
what we're trying to combat now, the mistrust in the medical system in research. But I found out that as a site principal investigator, because my patients know I'm invested in their care. I'm
mhm,
invested in improving their outcomes, and not only their medical outcomes. For example, I'll give you an example. For our clinical trials, I make sure that for our patients to come to the visits, we're able to provide transportation, we're able to provide home health services. So that's where the importance of addressing social determinants of health in all aspects, in research, in science, in policy, in advocacy. I recently got involved in some advocacy efforts in with the American College of Cardiology, talking about how we can promote multidisciplinary
mm,
team-based approach for cardiovascular disease, to
mhm,
improve cardiovascular disease outcomes. So I think it's a work in progress finally to bridge that outcome between science,
mhm,
research, and policy, but an environment of equity and belonging and inclusiveness, starting from the leadership to the execution of all these programs, and with a patient centered approach. I dare say family centered approach, the
mhm.
patient, everything, what is best, what is the science evidence for the patient. And I think to bridge this gap, there's been a lot of focus on community based participatory research. And I think that's where we're going. That's another important intervention or strategy to ensure like equity, to decrease the disparities, because we're taking the research to where the people are. We're taking medical care to where the people who are disadvantaged, who are disproportionately affected by this high burden of cardiovascular disease. So I think implementation research, the emergence of community-based participating research, a collaborative patient-centered framework that includes the clinicians, the policymakers, governmental agencies, teams, sponsors, everybody. I think that that is the way to go to ensure that we have equitable cardiovascular care.
And as I listen to you talk, the critical importance, the necessity of
Yes.
having community advisory boards
Boards.
that are
Yes.
included in clinical trials,
Right.
included in demonstrating access to care.
Yes.
And I'm also reminded of a project we worked on together called Children Are Our Messengers,
Yes.
Changing the Health Message. Well, and that's been a number of years ago. We don't want to date ourselves. It's been a number of years ago where many of those opportunities were employed, and we were very successful in including some of those and having a better outcome in clinical trials and research. How do we make access to research, to clinical trials? What do you think we can do to make that more accessible to patients and to patient families?
Yeah. Thank you for that question. I think that the concept of which you brought up, having a community advisory board. I think in the past, people design clinical trials, and if they know you're an investigator of color or you practice in the safety net of hospital, they're always reaching out to you after they've designed whatever it is, a clinical trial, a study that they want to do. But without thinking about barriers that unfortunately people of color are disproportionately affected to. So, like, for example, I will give you an example. People of color tend more likely to be caregivers, be it caregivers of their young children or elder caregivers. And when we said um, clinical trial appointments or visits for times that conflict with that, people are not likely to appear. Also, the issue of trust, like we talked about. So, I think to make clinical trial accessible, the idea or the notion of having a community advisory board that is not only included in the planning and the execution, but also in the publication, of whatever results come out of the clinical trial, and not only having them at the table, but listening to them and implementing what they think is best for their family. That's one way. Regularly engaging them through because usually clinical trial protocols are rigid, but I think that in order to make it accessible, involving the patient, the community advisory board, right at the execution, and be willing to make changes. We make protocol changes all the time based on the feedback of the patients. They also, I know you're familiar also with the barbershop trial, which is a
Mm-hmm.
pivotal trial that really showed the importance of, they used pharmacists right in the barber shop, and that's the
Mm-hmm.
concept of taking research to where the patients are. We've expected people to come to the hospital, but we need to take research, clinical trials, interventions to where the people are, and provide resources that make it easy for them. So for example, home health services. In the time, COVID has taught us a lot of things. We had no choice but to force ourselves to think outside the box. And I think that most of the lessons we learned from COVID, taking care to the patient, taking research to the patient, implementing the patient's voice through community participative research, having a community advisory board. I think those are some of the things that we can do to make trial accessible. Also make it easier for patients to engage in clinical trials by realizing the barriers, the adverse social determinants of
Mm-hmm.
health that may make it impossible for them to participate in clinical trials with a strict protocol. But we need to make nuances. We need to make um, options available that make it easier for them to participate in clinical trials and research. Having a diverse team, I can't stress that enough. People tend, and there have been research that shows that people even receive better care or are likely to engage in healthcare if the healthcare team looks like them. So I think that is also applicable to research. But you find out that as investigators, we are also what is called the minority tax. We're burdened with other mostly a lot of clinical duties that make it almost impossible to be a full-time researcher or clinical investigator. So that's where making funding available, to making it to minoritize clinical trial investigators or researchers. We know, like, there's a disparate funding, be it NIH sponsored trials for minoritized investigators. So making funding available and training, capacity building, for um, investigators that happen to be people of color. That will enable them to be able to participate in clinical trials, lead clinical trials, and involving them in the final product, to as a form of scholarship. So when we think about research, service, scholarship, we need to make sure that we provide resources to equip through funding and training for minoritized investigators.
We're joined by Dr. Modele Ogunniyi, who's a professor of medicine at Emory University Hospital School of Medicine in Emory University School of Medicine. It's always a pleasure to get to talk to you and to say hello to you. We have a final question for you. And what would you like the listening and the viewing audience to take away from this discussion today?
It's always a pleasure to talk with you, Mr. Payne, my longtime mentor. I can't begin to tell this audience how much I have learned and how much you've inspired me in this health equity journey. You have been doing this health equity journey even before health equity became a thing, and I just want to applaud you and your team for not giving up on this tireless journey. What I like to leave with the audience, first of all, I like to talk to the patient and their family to say that empower yourself with information. There's a lot of information out there. I want to, as we think about Black History Month and Heart Month, I will want to draw the attention of the audience to Life's Essential Eight, just put out by the American Heart Association. It used to be Life Simple 7, But this year they have added sleep, which I think that is every adult should have at least 7 to 8 hours of sleep, in addition to the heart healthy habits such as smoking cessation, minimal alcohol intake, controlling your cholesterol, hypertension, your blood pressure, and diabetes, maintaining a healthy weight. So I think that equipping ourselves with that information it's the message I have for patients. Make sure you schedule your primary care visit and an annual primary care visit. And lastly, know your numbers. The numbers I'd like you to think about, as we've talked a lot about hypertension and high blood pressure, is that a normal blood pressure, optimal ideal blood pressure, is a systolic blood pressure less than 120 and a diastolic blood pressure less than 80. By systolic, I mean the top number. By diastolic, I mean the bottom number. Knowing your numbers. Having a healthy total cholesterol less than 200. I know you know about the nuances, the elements of cholesterol, the good cholesterol and the the good cholesterol HDL and the bad cholesterol LDL. So those are things that I want you to know your numbers in addition to your blood sugar levels. So for the patient, in summary, know your numbers, be empowered to have this discussion with your primary cares. And if you have not, schedule your primary care visits. To the larger audience, to my colleagues, I think that the message I want to leave is that to promote equitable cardiovascular care for all, it requires a collaborative framework that places the patient at the center. And it involves work for all of us, including our clinicians, the policymakers, researchers, sponsors. And I think in addition, to reduce the disparate cardiovascular outcomes that people of color suffer, it is all hands on deck. It is no longer acceptable that we have this widening gap of cardiovascular mortality. It is important that we all work together and really focus on those social determinants of health that contribute to 80% of outcomes. In addition, we've made a lot of advances in medical care. I mean, if you look at the field of heart failure, there are a lot of clinical trials, new medications. Still, we have this disparate morbidity and mortality. So now is the time for us to think outside the box and look at other factors, the impact of structural racism, the impact of bias and discrimination, lack of funding, training that really disproportionate affect people of color, who are trying to do the work. We also need allies. We can't bear this burden alone. We need allies. We need allies who don't look like us as well, who will join with us and form this collaborative partnership as we all advance this work of health equity in people of color.
Molly, thank you so very much for joining us. And for you, our viewing and listening audience, thank you for joining us as well as we celebrate our 20th anniversary and beyond. I want to be sure that in these parting words, we remember that we need to be empowered, that we should always also remember that we have to seek the resources to help us improve our health. And from our colleagues here at One Joshua Group, and for those people who share in our quest for health equity, health disparities, and better empowerment, remember to be kind, to be courteous, and thank you. And join us for our future episodes of our 20th Beyond in celebration of this 20th anniversary. Thank you very much, and we'll get to talk to you again soon.
This edition of Beyond 20 is a Life Beat podcast sponsored by One Joshua Group, your strategic source of engagement to improve life through better health and information. For more information, visit us at theonejoshuagroup.com or follow our work on LinkedIn, Facebook, Instagram, and Twitter using hashtag OneJGCollabs. One Joshua Group, building capacity, expanding resources, joining what you know with what we've learned.